Good afternoon, everyone. My name is Denise, and I'm part of the marketing team here at CCD Health, Geb's healthcare company. Thank you for joining us today's session, Preparing Healthcare Operations for the 2026 fiscal year, Regulation, Technology, and Operational Readiness. It is thrilling to have so many healthcare leaders on with us today, right, when operational choices are more linked than ever. Now, we know topics like compliance, regulations, and fiscal planning aren't exactly the most glamorous things to spend your Thursday afternoon on. Trust us, we get it. But here's the thing, the decisions being made right now are the ones that will define how smoothly your organization runs in 2026 and beyond. So we promise to keep it practical, relevant, and maybe even a little fun. This discussion focuses on practical strategic insights, and we will explore the key shifts heading to 2026, evolving regulatory and payer demands, and the essential healthcare organizations need before rolling out advanced scheduling and revenue platforms. So today, we got two awesome leaders tackling these from different but super complementary sides. First up, we have Julio Tirado. He is an exec in strategy, data, tech, and innovation with over 10 years driving big businesses change in service-focused, high-performing organizations. Welcome, Julio.
Thank you so much.
Then we have Lorena Quesada, our compliance pro and law graduate with more than 7 years handling regulations and compliance for global healthcare spots. She brings tech and legal skills to keep everything above board, especially on risk management. Welcome, Lorena, to this forum.
Thank you, Dennis, for having me.
All right. Together, they will break down the big regulatory changes happening and coming this year, how regulations and payers are impacting scheduling and revenue flows, and what it really takes to bulletproof your operations for the future. So before we start, let's do some housekeeping. If you experience any issues with Zoom audio or video, please make sure to refresh your browser or app. Please remember that all of your questions are welcome. Feel free to drop them in the chat, and we will have a Q&A session at the end of the webinar where we can discuss these questions. If there's not enough time at the end of the session, no worries, we will address all of your questions by email. With that said, over to you, Julio.
Awesome. Thank you so much, Dennis, for the introduction. And thank you everyone for joining today. So let's take a quick look at what we are going to cover today, mainly in regards to regulation, technologies, and operational readiness. Today, we're going to deep dive into what organizations are actually struggling, where AI helps, and where it absolutely doesn't. And let's go ahead and tackle the four main points, which are what's changing in 2026 and why it actually matters now, how regulations and payers are reshaping scheduling and revenue, what operational readiness actually means before and after AIs and all the new platforms, and last but not least, how to future-proof scheduling and RCM. As we now head into 2026 fiscal year, as we all know, healthcare operation leaders are facing something very different. It's actually very different than even 2 to 3 years ago. This isn't just about new rules or new tech. It's about whether operational foundations can actually support what's coming. And with that being said, let's go ahead and start with the big picture. What structurally is shifting as we move, or are actually now into this 2026? Which the question is, why is 2026 a real inflection point? Historically, as we know, healthcare has landed change in layers, new regulations, system updates, and upgrades. 2026 is different because multiple pressures are covering at the operational level. We are seeing payers, regulators, and technology all touching the same workflows: intake, scheduling, eligibility, authorization, and billing. which is actually new. And regulation is really the first domino. So let's do something. Let's ground ourselves there and welcome Lorena and ask you right ahead. What's coming to play in terms of new regulations in 2026?
Thank you so much, Julio. I'm glad to be here and I appreciate the opportunity to speak today. As you mentioned, there are three key regulations that will directly affect operations in healthcare during this year, during 2026. But today I want to focus on the first one because even though it sounds like a budget policy, it has a very real operational consequence. Let's start with OBBA, One Big Beautiful Big Act. You have probably heard about the acronym, but what does this actually mean for operations? With over-related budget tightening, the regulatory tone has completely shifted. But first, let's take a moment to understand what exactly it is. OVA is a broad federal budget and policy package that directly affects how Medicaid, Medicare, and ACA marketplace coverage are funded, administered, and monitored. But here's the important thing, or the important part about OVA. The law was signed in July 2025 last year, but most of the real effect showed up between the late of last year, 2025, and 2028. But why is fiscal year 2026, this actual year, planning such a critical window? The real operational impact doesn't happen all at once. It unfolds between late 2025 and 2028. It will be a time for transitioning before OVA enter to operate completely. So why this matters for operations? Why we are taking the time to explain about OVA? For RCM, revenue cycle management perspective, OVA does not introduce a whole new set for billing codes. What it changes is the risk tolerance of the system. We need to be focused on being more preventive than reactive when we talk about law, regulations, and on. So in the past, front-end mistakes could be sometimes be corrected downstream. Eligibility errors could be fixed. Coverage gaps could be worked through. But under OVA, those mistakes move much faster to denials, delayed payments, or uncompensated care. So the margin for error trips. Uh, that's why the timing matters here, and it's one of the most important things. And it is not about go live moment. Another important point here is this is not a single switch flipping on January 1st. Some provisions take effect quickly. While, for example, ACA marketplace subsidy changes and stricter verification starting after December for 2025. So others like Medicaid, eligibility redeterminations, and work requirements must be implemented by state and by the end of 2026, with real operational consequence showing up in this current year and of course for the next year of 2027. So when we talk preparing for this year, we are really talking about preparing for a multi-year shift, not a single compliance deadline. Now let's translate policy into operations. So we have top three areas about taking into account and an operational focus. When key changes take effect, like I said before, OVA is going to take a time transitioning for understanding what are how is going to be the process for transform the actual system and adequate to OVA. So the first impact area number for this case is Medicaid eligibility and coverage churn. So the first major impact is eligibility churns. OVA increased how often Medicaid eligibility must be verified and introduces new community engagement requirements for certain populations. Operationally, this means more patients moving in and out of coverage, sometimes within the same year. All these same changes during this year. So it doesn't start in billing. It starts at the front door. If eligibility is run at scheduling, pre-registration, and check-in, everything downstream is already compromised. So authorizations may be invalid, claims may be denied, and patients may receive unexpected self-pay balance. No-show rates may increase. So here's the thing. Coverage instability becomes a workflow issue, not just a policy issue. So from a patient's journey perspective, this creates a very risk front door. Inaccurate eligibility, like I said, at scheduling, surprise, self-pay balance, and no-show rates. So the second impact area number that we need to be focused on is funding and reimbursement pressure. You will see a line item labeled OBBBA reduction. So what you will see is tighter margins, less flexibility, and lower tolerance for revenue leakage. In that environment, scheduling accuracy matters more, authorizations compliance matter more, and of course, clean claims matter more because there is a simply less financial buffer to absorb operational mistakes. And last but not least, the impact area number three is marketplace and ACA coverage changes. The third area is marketplace coverage. Subsidy changes and stricter verifications requirement mean some patients will experience plan changes, premium shift, or loss of coverage. But operationally, how this affects? If we can see intake, eligibility verifications, financial counseling, and collection, we can realize how important or how is the effect of OVA taken or can be related to. So again, what looks like federal policy becomes a daily operational challenge. What OVA really does is expose how connected the patient's journey actually is, how exposed is the patient journey truly is. Eligibility rules affect scheduling. Scheduling accuracy affect authorizations. Authorizations affect billing, and of course, is one of the most important things. Billing affects cash flow. So managing the full patient journey, but from first contact through the final payment, is no longer just a service model. It is a risk management strategy. And like I said, on first place, we need we need to exercise more about our mindset about risk and taking this kind of regulation and risk and loss as a risk management strategy. And increasingly, regulators are not asking whether you have a policy. They are asking if your daily operations prove compliance. That means accurate scheduling, verifiable eligibility, proper documentation, and clean billing alignment. So finally, in this fiscal year 2026, operational precision is no longer optional. It's a strategic protection. So moving forward from OVA, let's move on our language access. This topic is special because when we talk about access to language, we are talking about a human rights. So this is one of those topics that can be sound operational, even administrative, but it have a huge impact into the healthcare community. During this year, 2026, language access becomes a defined safety and compliance requirement. So the Joint Commissions update national patient safety goals effective from January 4, 2026, and build language access at the heart of the accreditation and quality evaluation. This is no longer best practice. This is an expectation. So what is actually changed? What this language access is coming to or new? So we have there are three practical shifts that we want to be aware of. The first one is quality must be stratified by preferred language. The second one is information must be understandable, not just provided. And the third is documentation and process must be formalized. Let's go through these three practical shifts to know more about them. So let's start first with quality must be stratified by preferred language. First, health system must now stratify quality outcomes by the patient's preferred language. This is a compliance requirement tied to equity and measurable outcome. Healthy system must now evaluate quality outcomes by the patient's preferred language. That means you are not measuring readmissions, complications, or patient experience overall. You are measuring whether outcomes differ for patients with limited English proficiency. So language is now tied directly to 3 points, like I said, equity, measurable outcomes, and compliance reporting. Second, about information must be understandable, not just provided. Every patient must receive information and in a language and format they understand. That includes registration, informed consent, very important for exchange information, discharge instruction, and follow-up care. That's very important. That is a very key point here. So this is not only theoretical. We know that when the patients with limited English proficiency don't receive clear communications, and it becomes clinical outcomes worsen, legal risk increase, and of course, financial performance suffer. So this is both a patient safety issue and an operational issue. And third, let's focus on documentation and the process how to be or must be formalized. In other words, we call someone when we need them, so it's no longer sufficient. The system is asking for more. You must be able to demonstrate how language needs are identified, how service is delivered, and how they are monitored and for effectiveness. So if you have a system and that system is not effective like you are waiting for, you need to check into your system to understand what is going on. So what looks like next slide, please. Thank you. What looks like a communication issue quickly becomes a compliance issue, a reimbursement issue, that is directly connected with the issue generated into the first communication or first contact with the patients. And one of the most important, especially for the healthcare place, is about the reputation issue. That is one of the most critical and the most important that we need to care of. So language access isn't just about fulfilling a checkbox. It's about ensuring clarity upstream. So that downstream operations like authorizations, claim, accuracy, and compliance documentation aren't jeopardized. So next slide, please. So with this final idea, it's important to understand that whether your scheduling team is in-house, hybrid, or outsourced, the expectation is the same. You must capture preferred language and communication needs at first contact and feed that into workflows that support consistent, we know to be consistent, as an interpreter access and documentation. Because if interpretation occurred, but it wasn't documented correctly, on a compliance standpoint, it didn't happen. So for companies certificated as ISO, if the information is not documented, it never happened. So that is why language access it is not, like I said, a checkbox. It's not a courtesy. It is not something that can be passed together on the flow, on the fly, because it touch access, authorizations, documentation, quality metrics, and of course a revenue integrity. So finally, guys, in 2026, language clarity upstream protect operational stability downstream. Now, speaking of the operational stability and regulatory shift, Julio, how is the AI regulatory landscape shaping for this year?
Thank you so much, Lorena, and thank you for explaining all about and all in regards to language access. Let's go ahead and talk about two main points. One in regards to AI, and one in regards to operational readiness. As we know, AI technologies have become more embedded into healthcare operations and clinical support. Compliance isn't just about following a checklist, as Lorena said. It's about how AI tools are governed, monitored, and documented on a daily use. Let's go about into three main steps here. First, human oversight and monitor remains central. Unlike a static medical devices, AI system can drift or degrade over time, as we all know. Failing to validate outputs continuously, particularly for those tools that affect clinical decision making or scheduling prioritizations or authorization recommendation, can expose an organization to risk. Second, data integrity and billing accuracy are key elements of compliance. Because AI relies on training and operational data, we all know this can be biased or incomplete if the data sets are so. And this can lead to coding errors or flawed utilization patterns. If those outputs translate into claims, organizations may face scrutiny under laws like the False Claim Act. Last one, third one, but not least, transparency, disclosure, and privacy obligations still apply. This won't change. Patients and regulators expect clarity about where and how AI tools are used in care and operations. HIPAA remains fully applicable to AI system handling PHI, and emerging state laws increasingly requires clear policies, clear documentations, and safeguards. In short, organizations must design compliance into AI governance, not actually adding it as an add-on or an afterthought. This must be handled from the beginning because operational mistakes can create legal exposure just as risk or as real as clinical risk. So let's go ahead and talk about or a bit about AI in healthcare, right? We all know that AI is almost a buzzword, but and there's an enormous pressure to do something with AI, as we all know. But AI doesn't actually fix broken workflows; it scales them. If your scheduling data is inconsistent, if your authorization rules are manual, or your intake process varies by site to site, AI won't fix that. AI actually will make the outcomes worse, not better. So, from a compliance standpoint, automated errors are still errors, just faster ones. So, the real question actually is what does operational readiness actually looks like on this scenario? And this is the main topic and where we want to tackle it and just put a mark on it. Operational readiness is less about being perfect. It's actually more about being consistent. Organizations ready for the next gen of scheduling have agreed on definitions on what an appointment type means, who owns authorization rules, and how changes affect the entire revenue cycle. We are seeing a shift away from localized workarounds towards centralized operational governance. That's actually necessary because AI driven platforms depend on a shared logic. They can function around or across dozens of undocumented expectations. So, how do we really prepare, and what will be a readiness framework? Preparation doesn't start by buying technology. It doesn't start with buying a system. It starts with understanding where scheduling errors cost you money or a compliance risk. Once that's clear, technology and systems become a force multiplier instead of a liability. It adds values. And that's actually how organizations are future proof, not just for 2026. It's actually more and beyond. If there's a message or a clear takeaway that we want you guys to have, is this: organizations that succeed in 2026 are preparing now, operationally, not just technologically. And the good news is that readiness is achievable with focus and clarity. Thank you so much.
All right. Thank you so much for that. I think that was a lot of information to process, but also a lot of insights to and takeaways. So let's move on. If you please, let's move on to the questions and answer session. So I have a question, and I think the first one suits you, Julio, to provide an answer. So
Right?
with yeah, sorry, go ahead.
Yeah,
Okay,
let's go.
perfect. All right. So, with all your experience in tech and innovation, what do you think are the top two, three next generation scheduling platforms or tools that you would recommend organizations to start piloting right now to handle this year's volume spikes without breaking the operations nor the bank?
Oh, that's a really good question. I Let's talk about three main ones, right? To handle volume spikes without overspending, and I will focus on three types of tools. I'll focus the first one on iCare One by the GAPS healthcare solution. It's actually designed to open up, optimize scheduling, patient access, resource utilization, and as well as a model for optimize and in regards to no call shows, no shows in the systems, right? Which is really good. The other one will be the Epic system or the Oracle Center, which maximize their AI powered scheduling forecasts and scheduling models. And last one but not least, Qnomi have for high value environments specifically. It improves queue management and appointment flow and overall throughput. But nonetheless, the key is choosing a platform that predicts demand, adjusts scheduling dynamically, integrates easily with your current systems, and can be piloted in one high volume area before scaling. Smarter scheduling, not just more slots, is what will absorb the 2026 volume pressure.
Definitely. No, I agree with you. All right, so let's move to the next one. Um, this one might be for Lorena. Lorena, as a compliance expert, can you share a real world example, a real world scenario of how the new 2026 regulation has already tripped up payer expectations in revenue workflows, and your what would be your best tip or advice for managing those risks upfront?
Of course, Denise, thank you. Well, since Centers for Medicare and Medicaid Service and in 2026 prior auth rule require payer to decide expedite request in 72 hours and standards in 7 days. So early test shows denials, speaking for incomplete scheduling data, hitting revenue very hard. So here comes the tip. Automate eligibility checks at booking via API or application program interface, plus daily QA training. With that tip, we are going to cut denials by 25%, mirroring high performance fixes. If we have this tip and we put it into practice, making the process more automate, and of course using a AI, like we'll explain, I think the process can improve.
No, yeah, there's definitely always some sort of obligation and responsibility on humans still, besides all technology. And I think there's time for a last question. Um, I don't know who of you my answer, so feel free to chime in, both of you. The question is, what is the one non-negotiable operational change, either if it's tech, process, or team setup, that every mid-sized healthcare organization, like any folks on the call right now, would need to make by Q2 of this year to stay ahead of all of these regulations, payers, and revenue stability during patient surges?
Right. I can go ahead and chime in first.
Sure.
From a strategy, tech, and analytics standpoint, I think the visibility is key. I think my recommendation will be to rolling out cross-functional dashboards, tracking KPIs like effective appointment rates or authorization turnaround times, and integrate them into your current systems and put them on a platform with real visibility. I think that will prevent siloed bottlenecks during surges. I think that will be my recommendation.
Well, on the compliance side, enforce weekly reviews of those KPIs with clear automations by Q2. This aligns fiscal year 2026 with IPPS, uh, which is in patient's prospective payment system. So cost and prior auth rules, looking in clean claims, and a stable revenue even under payer pressure will be very useful tool too.
Perfect. Well, thank you. Thank you, Julio and Lorena. Thank you both for this thoughtful and very grounded discussion, I think. And thank you, everyone who has joined us today. So, before we wrap up, I want to quickly mention that we will be sharing our latest industry report with all the attendees. The report takes a deeper look at many of the themes that we discussed today, including regulatory pressure, payer expectations, and operational readiness for next generation scheduling and revenue workflows. You will receive access to the report following the session, along with a recording of today's discussion. Thanks again for your time, and we look forward to continue the conversation in our next webinar next month. And for more information about CCD Health services on scheduling and RCM, please visit ccdcare.com. I hope all of you guys have a great day, and thank you for joining us.
Thank you. Bye bye.
Bye.